Every year in Lent, we have a special parish project, and part of that project is always about fundraising, raising money for a particular work to be done either at home or overseas. But also it's about learning about the needs that this project seeks to meet, learning about the circumstances of the people whom the project seeks to serve. And this year, we are raising funds to help the Canadian Network for International Surgery begin a midwifery program in Nigeria, training midwives in Nigeria. This organization is led by a parishioner of St. Thomas, Dr. Ron Lett. And I'm so pleased that this morning, instead of a sermon, we get to hear Ron talk about the work that his organization does and why it is so important for us here at St. Thomas to be supporting it. Thank you very much, Ron, for making this presentation this morning, and over to you.
Good morning. Well, I'm glad Michael's I hope at the end of it, everyone is happy that they got a presentation from me and not a sermon. We'll see how it goes. But learning is what I'm about. Yes, I'm a professor of surgery. I mean, people know me as a parishioner and as father of Lawrence and Lana and husband to Elsie. But today, we're going to have some lessons, so I hope you have your notebooks ready. I'm going to show a PowerPoint video, but before we get there, maybe I would like to give two brief introductory lessons. First of all, a little bit of vocabulary. Primipara, or gravida 1, para 1. That's a pregnant woman that has never delivered. Okay, so it's her first baby. Multipara is a woman that has had more than one delivery. So that was relevant to what you're going to be hearing. In addition to that, we're going to talk about a randomized controlled trial. Now, I think before the pandemic, you probably hadn't thought much about randomized controlled trials, but you'll remember during the pandemic, when we were waiting for the vaccines to come, they were doing randomized controlled trials of the Pfizer and the Moderna and other vaccines, where one group got the vaccine and the other got a placebo being a representative of that medication, but not the real thing. So I'm going to present a randomized controlled trial. So I think that's enough of the vocabulary lesson. And I would just now like to talk about Nigeria. Nigeria is the most populous country in Africa. It has all the best and all the worst of Africa in one place. But that place is quite huge, and the population is likely around 120 million people. It is the largest economy in Africa. It outstrips both South Africa and Egypt. So it's a huge country, a huge economy, and it's very important to Africa, which means it's important to the world. Now, the problem we're addressing is maternal mortality, and we are addressing it in Benue State. Benue State is the state I worked in as a junior doctor many years ago, but I was happy to have the opportunity over the last few years to go back to address the maternal mortality problem. It may be as high as 1 in 100 pregnancies result in a maternal death. It's scandalously high. it means that no one in Benue State doesn't know somebody that's died of a maternal death. That's when you get to a rate of death of that high. So that is, the situation we're trying to address. Now, addressing maternal mortality in Africa and in Nigeria is not a new activity of the Canadian Network for International Surgery. In fact, we were the Lenten Project in 2016. I was scrolling through my Instagram account to find out when I received a check on behalf of St. Thomas from Cheryl, and it was back in 2016. And I believe in 2016, the Outreach Committee was recognized as the Volunteer of the Year by CNIS. So I was very pleased when a few months ago, I got an email from Cheryl asking, is there anything, that the Lenten Project could direct funds for with CNIS? Well, I can tell you, of course, the answer was yes. And I felt, going back to midwifery, in 2016, the project was midwifery in Tanzania. But I really have been looking for a way of returning to Nigeria to do more midwifery training. We conducted this randomized controlled trial. During the pandemic, we developed digital means of training. And we had a randomized controlled trial of standard teaching, similar to the teaching you supported in Tanzania, to digital teaching. And we did that trial, and we showed that it actually was as effective as small group teaching, but it was more efficient because we needed fewer instructors. So it was quite successful. However, because of the pandemic, we did the randomized controlled trial, we got excellent data, we left, and we've never been able to go back. And so when Cheryl said there's some possibility of funds, I said, well, I really would like to go back to Nigeria. And it's timely in the sense that you will see groups of midwifery students in the video PowerPoint I'm about to show, but their classmates, the following group is going to graduate in August. So we've got a small window of opportunity to follow up and teach those other students. Also, I'm hoping to teach the instructors because, in the randomized controlled trial, you have one group digital and the one group standard treatment. Well, the standard treatment was the instructors teaching the other groups. So they didn't really have an opportunity to learn and benefit from the digital teaching. So my hope is that we are able to return to Nigeria and carry on with the introduce the teaching so that it can be carried on, and not just that one group of students. They certainly did benefit, but have other groups of students and the faculty benefit from it. Before I share my screen, I would just like to point out that Nigeria had a presidential election yesterday, and it's presidential elections in Africa and in Nigeria can be very, very dangerous for people. And, so I think when it comes time for the prayers of the church, I think it would be good to recognize the risk that the people in Nigeria are at as they try and maintain this huge democracy. So, and the interesting concern is that a third-party candidate has a possibility of winning, which the two major parties are not going to be happy with. And I mean, I don't know what the result will be, and we don't know if there will be any, corruption or anything that affects the result. But I think I would actually direct your attention to the presidential election in Nigeria. It's important. It's important for the world, this huge economy, this huge number of people. And of course, it's full of many important people. So are there any questions before we carry on? And Michael, you didn't give me a time limit, so so I want a revenge on all those people that have the Reverend in front of their name for when they've missed a chance to sit down.
I have a question, Ron.
And I have a
Okay.
question.
Erica here in the church.
Okay, hi, Erica.
Hi. And maybe you're going to be telling us this later. My curiosity was, what are the conditions that mean that so many women are dying in childbirth?
Yeah, there's a number of conditions, and we can't address all of them, but one of the reasons is lack of skilled birth attendants. And so this is what we're addressing in this, is by giving midwifery students who will be out in practice skill. And so about 50% of the mortality of women in these situations can be addressed by successful midwifery training. And so we are going to be so this program is working on that issue. And specifically, you'll notice one of our modules is respectful care. And you learn a lot when you're doing these, like I learned a lot. And I thought respectful care was just important because why should you be, disrespectful to your patients? But it actually has an effect on mortality. We teach respectful care to the midwifery students because if there's a lack of respectful care, the other issue that we face causing mortality is women don't come to the hospital or the clinic for care. Because why should I, go and be abused? Why should I be disrespected? So by having respectful care, you will have more women coming to care, being willing to come to the health center or the hospital for delivery. So the lack of skill is one answer, Erica. The other area is the lack of delivering at home.
Hi,
Okay.
Ron.
Hi.
Thanks very much for this. My question was, you said it was one in 100 in terms of the mortality rate during, during birthing. How does that compare to Canada? Just so we could put it into perspective in terms of numbers.
We have about 5 per 100,000. So, if you were to put that 1 in 100 to 100,000, that would be 1,000 per 100,000, compared to 5 per 100,000. And of course, every maternal death in Canada is investigated, but often they are related to the underlying condition of the mother in Canada. There are periodic unexpected deaths, and there is, there is death with delivery that every mother takes a risk of. But a lot of the mothers in Canada are older, have underlying, cardiac or diabetic conditions. And while these women in Africa often are in perfect health. So, but yes, it's a huge difference. Okay. Those were both accurate and important questions. Let me try and share my screen. And technology within technology is not always the greatest. And if I have flubbed things and have to go back and things like that, please accept my apologies. Okay, we're going to go ahead and I'll interrupt if necessary. So the course is called Fundamental Interventions, Referral, and Safe Transfer for Midwives. And you'll see in this photo, the nurse midwifery students have their phone in front of them, and they're learning how to do a delivery. And you can see the delivery model in below, and they are looking at the phone, how do I do this? First for Clinical Officers was developed and implemented in Ethiopia and Tanzania as a 3-day course. First for Midwives was developed and implemented in Tanzania, with 1 day of surgical skills irrelevant to midwifery removed, resulting in a 2-day course. Recently, First for Midwives was studied in standard and digital form in a randomized controlled trial. It was conducted over 6 days and it included an OSCE. Outside of the context of a trial, it could be done in 4 days. With an OSCE, full implementation would take 5 days. The digital version could be conducted independently as continuing medical education, which could be 1 day a week, for example.
What you're looking at right now is the screen of my phone. Like the students, I've uploaded the Moodle app, which you can get on Google Play Store, onto my phone. They have registered at the Canadian Network for International Surgery site. You see the dashboard initially, which shows recent activities, but we can go to the home page, and all our modules are defined as courses according to Moodle, and you will see the modules of the first course, the Fundamental Interventions, Referral, and Safe Transfer. We evaluated it in Nigeria using the MAID initiative, and that module is there for that purpose. But the learning modules are patient risk management, wound management, basic obstetrics, community maternal risk, respectful care, and impairment at birth. So those are the 6 modules that are available on our digital version of the Fundamental Intervention, Referral, and Safe Transfer course.
So I'm going to try and stop there just for a second. Just a point is that this learning on a phone is something that the millennial learner likes. They prefer to be in control than to have to listen to a lecturer. You'll see on the presentation you're seeing right there, there's module 1, patient risk management. And you'll see the picture, you see me standing in front of a whiteboard giving a presentation. And the students prefer that than the person being there. They can scroll it back, listen to it again if they have to. They can, there are interactive questions during it. And so I know that for people of our generations and other generations, this is not something you would actually probably like, but it's very much liked by the current millennial and younger learners.
We enter the Moodle.
So we're looking at module 1 now.
Look for the available courses. The first module is patient risk management.
And
the app through Microsoft Forms. So they fill out the information on the patient. Where do they get the information from the patient? From the case studies. So there are 9 case studies for them to work through. They have a quiz question. And at the very end, they have a modular quiz, which in this case is on Google. And so they go through a true and false question, and these are marked to see how well they understood what was going on. So at that point, they have completed Module 1. After completion of Module 1, at any time, but often the next day, they would do the module on wound management and basic surgical skills. There's some text material, there is videos, they have a video introduction, they have a quiz question where they're asked questions about local anesthesia and wound management. So they go through this And there's only one answer on this one, and so we will get a correct answer, and they go to the next choice. And when they complete the quiz, they can check their answers. And if they didn't get 100%, they're encouraged to go back and redo it. They have interactive exercises again. What are the names of the instruments? They've been taught the names of the instruments on the lectures, but now they'll do a drop and drag. So here we have adds and forceps, so they can put it there. Here we have suture scissors, so we can drop that there. And they can check. And they go through until they know all 9 instruments. Now this, unlike the previous exercise, actually has practical assignments. So they will learn how to repair lacerations, for example. So they will have reading materials, they'll have videos, but then they'll go to the practical assignment. And what they have to do is record a video of themselves actually doing a laceration repair. So they will be provided with the model and the instruments and the sutures, but they need to perform that procedure. And again, at the end of doing all their assignments, including draining an abscess and showing that they know how to do it, they will have a formative evaluation where they'll answer 10 true and false questions. So this will follow up on what they need to know for this module. And that is the end. Module 2 continues in this demonstration to show the submission of one video assignment. So I hope you're seeing this, because this is what the classes actually look like.
My city is on it. Draw it again, draw it again. Yes. Good. Tie again. Make it frame. You have lost it. Tie it again. Leave that one.
The next module is Basic Obstetrics. This is the largest unit and usually takes a day and a half for them to complete. There's reading materials. They have a basic obstetrical quiz where they have to answer questions. Multiple choice questions, and you'll see when they get questions wrong or right, they get information. So management of antepartum hemorrhage, start an IV, order blood transfusion, record vital signs, so they can check the answer after they've assured that they're okay with it. So, yes, starting an IV is important. They didn't choose vaginal exam, which was correct. There's a discussion about the availability of blood, and then a discussion on assessing the patient status with vital signs. So all of the quiz questions have responses for every one of their choices. I went back a bit too far. We're still on basic obstetrics. And like the wound management, they also have watch videos on breech delivery, for example. But they also have reading material on breech delivery, and they have a practical assignment where they must watch the videos and then demonstrate how they would do a breech delivery, which then can be marked. So there's vacuum assisted, there's material on postpartum hemorrhage, again, videos, how to start an IV, and then they show how they start an IV. So that even practical skills are demonstrated and practiced through this digital model. And after they have gone through all the material, they will again have case studies, similar to what they had before with the wound management. They'll use the patient management form, and they'll have patients with histories that they need to go and to the patient management form and complete what they think about the management of this patient and what is the risk of this patient. I'm just looking for the modular exam. As in all modules, they will end it with questions about the content of that module. So that is the big unit, Basic Obstetrics. Again, we'll have an example of a video assignment. The students took the video on their phone and uploaded it to their Moodle app. Subsequently, they'll do Module 4. They'll look at the Community Maternal Risk app. So they have to download the app from their Google Play Store and then calculate the risk of their patients. There's an introduction to the CMDS. There's a video on how to calculate the score using the app. And then, again, there will be patients that they have to manage. So here we have a patient that is gravidas 6, para 4, and the CMDS app calculates a prenatal score, so they'll be asked to calculate that and give that result, and it calculates a third trimester visit. And again, they'll have to calculate that. After they've completed that patient, they can go on to the next patient. And there's actually 11 patients for them to calculate. This patient at third trimester has a systolic of 135 and a diastolic of 89. So there would be a risk score calculated according to her risk of having preeclampsia or even going on to have eclampsia. So that is the Community Maternal Danger Score module. I'm going to demonstrate Module 5 is on respectful care. So the students enter respectful care and they go through a presentation on respectful care. And in that presentation, there will be discussion of the different dimensions of respectful care. In fact, the 7 dimensions. So they will go through and read about this and have discussions. And then as they go through this module, there are questions within the lecture. So here's a question about when is it permissible to refuse a patient care? And they can answer as many as they want. If they get them all correct, they get 4 out of 4. They move on to the next patient. Patients have the right to the best possible care. Well, true is an easy answer, but what does that mean? Best healthcare can be assured by not explaining reasons for delay? I don't think so. Avoid unnecessary procedures? Probably. Always have a skilled midwife. Offering best skilled care to everybody. So this student, in my case me, got 3 out of 3. So that it is interactive and makes them think about respectful care. At the end of their video with quiz questions, they go on to an assignment. And their assignment is to prepare a scenario demonstrating respectful care. Originally, we had that as a written assignment. Now we're using audio. They make an audio recording and they prepare 2 scenarios, one with respectful care, one with disrespectful care, and they upload the audios. The next unit is short, and so I'm going to put it together with respectful care, and that's impairment at birth. We tell the students how important it is that they, as midwives, are capable of determining and recognizing impairments at birth, and they get a presentation which shows them recognizing impairments at birth. So they see the material, the topics they need to know, and then they go on and they have to understand impairments at birth, how to examine the patient, and then they go through things like occutaneous albinism, hydrocephalus, and all the orthopedic abnormalities. Then, to make sure they know these different abnormalities and impairments, they do a drop and drag exercise. So here, they've got congenital hip dislocation, spina bifida, and limb impairment. So we've got spina bifida goes here. They can check that. It's correct. We have to retry before we can go again. So they do an exam, they do a lecture on impairment, and then they do a drop and drag exercise to make sure they know it. And then at the end of the day, they will have a formative assessment of what they learned. So they will again have a true and false quiz questions concerning the abnormalities or the impairments at birth. So that is the conclusion of unit or module 5 and 6.
Good morning, ma'am.
Good morning.
How are you? My name is Nurse Bless.
You're listening to an audio of a respectful care exercise.
Dara Timothy.
Okay, what is your husband's name?
Timothy.
Your home address, please.
Behind Lower Gateway.
I think the audio is not that good, but you can hear how kindly the student is talking to her patient.
Have you had miscarriage before?
No, this is the first time I'm taking.
So I've already discussed the results, and we see this is one of the groups of students at one of the schools in Nigeria. We taught another group equally as large at another school. So that is the idea, that all of these students have learned how to be better skilled at what they're doing. And the objective, of course, is that they will reduce the maternal mortality of Nigeria. So I'm open to any more questions. I think the challenges of Zoom weren't perfectly addressed. I hope that the people in the church were able to watch most of that. And
we have a question, Ron, in the church.
yes?
Hi, Ron, it's Erica again. I actually have two questions.
Yeah.
One is the content of the course, is it geared mostly to births in hospital, or are they also able to use it for births in people's homes? So that's my first question. And my second one is the material available to the students after the course to review if they need to?
It is not designed for home deliveries. There is another course, there are other courses for that purpose, but we're really trying to promote delivery at health centers, and this is where where these midwifery students would be located. The program for home deliveries is much more basic, and there's a program, we don't have it, but it's called Helping Mothers Survive, and it's just to try and have home birth attendants do some basic care and recognize when they need to leave home. So that, and we actually even have an app that we've developed for health extension workers to identify women who should not deliver at home and warn them that they should plan to have their delivery in a health center. Yes, the materials available online. We have after the students have done the course, we enroll them in what we call the legacy program, which allows them to access all of that material anytime in the future.
Ron, we have a question from Cheryl.
Okay, hi Cheryl.
I'm just going to read it out for her. This course appears to be entirely in English. Is English fluency a barrier to access to the course, or is English universal in Nigeria?
English is the language of instruction in Nigeria. Okay, it's the only language that is capable of being used throughout the country. Other than the students have speak Pidgin English among themselves because they come from so many different ethnic groups. So I learned a bit of Pidgin when I was there, and that made them very happy. So it's when you listen to it, it sounds like English, but it's and used to be considered sort of slang, but it's now officially a language. But no, the English is the language of instruction.
Thank you very much, Ron, for this wonderful presentation.
You're welcome. It was a pleasure. And it's a little bit, unusual to be doing this on Zoom and not quite being able to see anybody's faces while I'm doing it. So hopefully it all came through.